Ma'am, over to you.
Thank you everyone for joining us for today's session. As mentioned, today we will be starting with the first part of GI symptoms. Am I audible, Shripriya? Suddenly.
Yes, ma'am. Yes.
So today we'll be dealing with the first part of GI symptoms. We have two sessions on GI symptoms. And today we have Dr. Hassan as our faculty. He's based in Bangladesh, trained in Bangladesh in MBBS, and he's trained in medical oncology from India, and he has done his diploma in palliative medicine from South Africa, University of Cape Town, and he has done his diploma in elderly care from Ireland. Currently, he's working in Lesotho Cancer Clinic, Africa. Dr. Hassan, you have to tell us where Lesotho is. We had to Google when we heard the name Lesotho, but yeah, just anyway, I invite you for the session. Currently, he's a specialist in palliative care and working in Africa, and he has kindly agreed to share his experience and knowledge with the group. And Dr. Hassan, these are a set of doctors around, more will be joining in, around 35 to 40 participants from across the country and some people outside India also. Yeah, welcome to the session, Dr. Hassan.
Thank you, Madam Dr. Sripriya. Very good morning for this introduction to me, to the whole team here. I can tell you that this morning is a very special morning for me as well, because I'm joining with colleagues from different parts of the world, mostly from India, Ireland, and Myanmar, as I'm informed. Lesotho here is very cold now. I know in that part of India, Bangladesh is very warm now. I don't know about England and Myanmar, but I would love to know that. So I have sometime I'm sneezing also, and I'm with the tissue paper sitting here for the sharing today. So all of the participants here, I want to greet you from our Lesotho, Africa, who are interested in palliative care activities, and that's why I'm super excited. But let us take this today's session not as a teaching or something like that, because what we're going to discuss today are already in your mind, in your thoughts. It is just an interactive session. I will learn from you as well. So let us begin the slides, and if time permits, I would like to know you individually. Okay, Madam Sripriya, can you please share the slide for me?
Yes, sir.
Yeah. When she's still sharing the slides, yeah, thanks. Okay, let's start the first slide, please. Today we're going to share ourselves with the nausea, vomiting, and constipation. There are different definitions of nausea and vomiting. So in South Africa, Cape Town, they say that the patient defines sensation to vomit, associated autonomic signs as pallor, diaphoresis, and tachycardia, involving a subjective component unique to the individual. And from Dr. Lucas Radbruch, I was discussing with the professor a few weeks back. So he said that the unpleasant feeling of the urge to vomit, often accompanied by vegetative reactions such as paleness, coldness, salivation, tachycardia, and diarrhea. And for vomiting, it is said that the forceful regurgitation of ingested food, it involves constellation of actions, including contraction of the abdominal wall musculature, pylorus and antrum, rise of gastric content, decreased lower esophageal sphincter tone, and esophageal dilatation. Next slide, please. Colleagues, you will stop me if I'm very fast, because I am told that only 60 minutes have been given. So let us run through the slides. Then I would love your questions and comment and discussion after the session, please. Okay, there is a term called retching, the attempt of vomit without actual expelling of stomach contents, characterized by repetitive diaphragmatic and abdominal musculature movements with a closed glottis. Next, please. Okay. So when in the consultation room, you're sitting, I'm a patient coming to you. So I'm complaining about my nausea and vomit. So how will you assess, or how I will assess my patient? Frequency of and intensity to be asked, like how is the nausea? Is it slight, moderate, or severe? How is the vomit? Is it how often it is coming? How frequently it is coming? How many episodes in a day? Or how much amount approximately? And then let's look for the participating factors, like what is triggering the nausea and vomit? Is it food, or is it chemotherapy, change of position? What are the type of vomits? Is it food, bile containing mucus, or blood containing vomit? And what are the other symptoms associated with the vomit? Is there any loss of appetite, or increased salivation, or retching, sweating, tachycardia, or hypotension? Next, please. Then we look for the common causes of nausea and vomit. As we have mentioned already, drug metabolite, chemotherapy, toxic causes like infection, uremia, cytokines, medications like analgesic, cytostatic drugs, and some GI causes like alcohol ingestion, NSAIDs. Is there any constipation or obstruction diagnosed, paralytic ileus, ascites, compression from the cancer? Centrally induced nausea and vomit, CNS related, like raised intracranial pressure, or is there any meningitis diagnosed? There's a term called anticipatory nausea and vomiting. I have learned that few colleagues here today who have already been exposed to palliative care, and all of you are practicing doctors. So please share your ideas on this anticipatory nausea and vomiting in the discussion part. Let's go to the next slide, please. Okay. Now, the physiology of nausea and vomiters, just refreshing, like if there is any fear, dread, or anticipation, inner ear stimulation in cochlea and vestibule, any bloodborne emetics, vagal, sympathetic, glossopharyngeal afferents stimulation. Next, please. Okay, this is a cartoon just got from the internet. Just we have mentioned them, like any like episodes of vomit which come from GI tract, or for stimulation, or from the auditory, like inner ear stimulation, or the receptor stimulation. We'll talk about it later. Next slide, please. Okay, there is some a few factors like chemoreceptor trigger zone we have to put in mind, which is when it is triggered, it causes the emesis, which is also called the area postrema. All of you are already aware of it. So it is located in the dorsal surface of medulla oblongata on the floor of the fourth ventricle of the brain. Next slide, please. Okay, so any emetic tone, it can trigger the chemoreceptor trigger zone. It can be like any vestibular input or drugs, toxins metabolized via systemic circulation. It passes to the chemoreceptor and mechanoreceptor of liver, and then stimulate the chemoreceptor trigger zone. Chemoreceptors and mechanoreceptors of the GIT mucosa, it stimulates via the vagus nerve, the chemoreceptor trigger zone. Then also in viscera of head, neck, and thorax, and abdomen, and pelvis, they can also stimulate the chemoreceptor trigger zone. Next slide, please. We're not going to talk about so much pathologies, because pathology of vomiting, nausea, constipation, you already know. We'll look more in the clinical aspect. So toxic drugs, metabolites, and chemotherapy, they stimulate the chemoreceptor trigger zone, or either directly or indirectly by irritating the stomach lining. Medications like iron, it can stimulate the stomach lining. And opiate drugs, which can cause nausea and vomiting, which occurs in 90% of the patients. So opiate tolerance, as we all know, that it develops within 5 to 7 days. Next slide, please. So chemotherapy-induced nausea and vomiting is seen in 80% of the patients. It leads to poor compliance to chemotherapy and interruption to the treatment, and complication in disease management also, and it leads to deterioration of the quality of life. Next slide, please. So anticipatory nausea and vomit. So it is defined as conditioned, learned, and physio and psychological nausea and vomit. So it comes when somebody is thinking that either he or she is going to have a chemotherapy, or it is observed in more than 30% of cancer patients will go for chemotherapy. It develops hours before the expected date of chemotherapy administration. It is triggered by discussion and thought of chemotherapy drugs. One thing is very interesting. When we travel through the flight, the next seat person is just pulling out some magazines from the back seat. If you can see, there are some like those packs to vomit. If I see it, I feel myself like I feel like to start vomiting. Okay, next slide, please. Centrally induced nausea and vomit when there is a raised intracranial pressure from the space occupying lesions in metastatic or primary cancer. Or there might be some infection like meningitis, encephalitis, which cause the cerebral edema. The cerebrovascular accident, stroke can directly trigger the receptors in the brain, or traumatic brain injury can cause the nausea and vomit. Next slide, please. Now, the GI causes of nausea and vomiting. When patient comes to us, they will never talk about constipation or bowel habit. This either the clinician or the relatives, they will start the discussion, as I have observed in my clinic, in cancer clinic. Yesterday, I was seeing a patient of recently diagnosed gastric carcinoma, a 45-year-old female. She's coming with her sister with the biopsy report, and she was telling about her pain and anorexia, but she never mentioned the constipation until I asked, "How is your bowel? Like how do you poop?" So then she started talking. Okay, I don't go to toilet for last 1 week. So constipation is very important to ask every patient. Then look for the bowel obstruction history or any ion imbalance like hyponatremia, etc. Next slide, please. Okay, there is a term called fecal vomiting, which is a very deteriorating condition which deteriorates the quality of life of a patient and the family members when the vomit material is fecal origin. Common symptoms, it is found in gastrojejunocolonic fistula or intestinal obstruction in ileum. Next, please. So what are the management principles of nausea and vomiting? As palliative care practitioners, we always look in the palliative care way. So regular clinical examination, like history taking, is the first thing for the clinicians. Assessment by taking detailed history from the patient and relatives through physical examination, investigations. The first, then the next thing we have to advise the patient that is he feeling any smell, bad smell before the nausea and vomit. Then do you have any like hard stool, or do you the bowel habit? How many days interval you go to toilet? And then look for the hypercalcemia, hypoglycemia, hyperglycemia, those causes, and try to hydrate the patient if the patient need it, and prescribe medications at the end. Next slide, please. So while prescribing the medications, antiemetics, we have to choose the correct drug and correct doses and correct route of administration. Do you choose the oral, subcutaneous, IV, or IM? It depends on the individual patient's condition. We'll start with one drug and look into the cause and likely receptor. Then we go for the second drug or combination like this. Next slide, please. Okay. So the for choosing antiemetics, ESMO in 2016 consensus recommends that metoclopramide as the drug of choice. I will also listen from your concerns individually from dear colleagues today who are participating in the session, your idea of choosing antiemetics. Then alternative to metoclopramide, they said haloperidol, low dose, 1.5 milligram to 5 milligram per day, per oral or subcutaneous. It is used in metabolic and drug-induced vomiting. It can be combined with metoclopramide. As you all know that haloperidol acts on D2 receptor side in chemoreceptor triggered zone. But we have to be careful not to use metoclopramide with buscopan and not use of metoclopramide in bowel obstruction as well. Next slide, please. Okay. The other antiemetics are ondansetron, like gansetron, all the cetrons, which are a 5-HT3 receptor antagonist in the GIT mucosa and CTZ. And doses are 8 milligram per oral, slow IV 8 hoursly. But we have to be careful using ondansetron because, as we all know, that ondansetron high dose can prolong the acute interval. Next slide, please. Okay, there is something a step ladder approach for choosing drugs. Like when we use metoclopramide, then haloperidol combination, or differently, either metoclopramide or haloperidol. If we don't get a positive outcome, we go to the levomethomazine nutritional counseling for the patient. If even the patient doesn't respond, then we go for the steroids and also the cetrons. Next slide, please. So palliative discussion with the patient and the family for nausea and vomiting is very important. We have to educate the patient and the family about the cause, suspected cause, which is causing that nausea and vomiting. Then we encourage the patient for enough hydration, encourage the regular antiemetic to be taken, modification of diet, as we advise the patient for small meals more frequently, not in a huge bulk amount of food to take at the same time, and avoid drinking fluid in between the meals, either before the meals or after the meals, to advise the patient to drink the fluid, and avoid food causing nausea. It will also depend on individual patients. One patient can have nausea in one type of food, and the other can have nausea in other type of food. And avoid very much sweet, very spicy, greasy, fatty, or strong odor foods. And for better taste or better smelling, can use ginger or peppermint. Next slide, please. Okay, so the patient should be advised to eat in a place where the patient feel comfortable. It should be well ventilated, free of strong odor, in a family environment. If the patient choice is to be alone to eat food, let us allow him to sit alone and have food, or is better way to advise the patient to be in the family environment with her or his near one and dear ones to have food in the same dining table. And good oral hygiene is very important. Chemotherapy-induced mucositis, things like those adverse effects, we have to look into it and treat the patient in that way, to advise the patient to keep good oral hygiene. Next slide, please. Okay, our goals of management of nausea and vomit are free from nausea most of the time of the day, and minimum episodes of vomiting. Enjoy the eating with a meal, and adequate hydration. Next slide, please. Now, I want to discuss constipation, but before that, may I please invite the colleagues, knowledgeable colleagues here, for any comment or question what we have just discussed. Madam Cypriot, can you please read any inbox chat message so far? Then we can discuss on it.
No, there are no chats so far. I think you can
Okay.
proceed with the presentation.
Colleagues, in that case, can you please raise hand and put your question and comment? So far we have discussed, then we'll go to the next topic of constipation.
Yes, Dr. Vandana, please go ahead. Or can you unmute and speak? You are muted.
Yeah. Thanks. Good afternoon, ma'am. Good afternoon, sir. My question about nausea vomiting would be that when we are treating patients with opioids, we start with the step ladder that is there now. That is metoclopramide and haloperidol. Step 1 that applies to all types of nausea vomiting, like that is when it is induced with opioids or other chemotherapy, or the step ladder changes according to the cause of nausea vomiting.
Okay, namaste, Dr. Vandana. Thanks for your good question. If I can understand you well, that you are asking about the opiate-induced nausea and vomiting. Yeah, yes, opiates. I was talking to the prof of Germany, Dr. Lucas. So the most naughty opiate is tramadol, which is called the best emetic in the world. Like, unfortunately, we cannot skip the tramadol for pain management. But when you start using tramadol, it can induce vomiting itself, like the other opiates. But tramadol is the mostly emetic, like king of emetics, we can say. So for when we prescribe tramadol for any cancer pain, even though patient is not vomiting, it is advisable to use an antiemetic in the adjuvants with the pain relief medication. And the first drug of choice, as you have just mentioned, is metoclopramide to be prescribed. And then we see, like, the following within a week, we can ask the patient for follow-up, as because the patient, we have started opioids, so not a long checkup, a short follow-up date, and that date you ask for the pain relief. And we also assess the patient for vomiting. Is the patient started vomiting or constipation? Okay, so start with metoclopramide, then we can add, we can go to the step-ladder approach. Okay, haloperidol can be attached to the, if the metoclopramide is not adequately stopping the vomit or nausea, we can add haloperidol with it, like this, and that's how it goes. Thanks.
Thank you, sir. Thank you so much. So we wait for 1 day, sir, after 1 week after starting the drug, and then after follow-up, we decide whether to add on to the second.
Okay, and another thing, Dr. Vandana, like we have to know the socioeconomic condition of the patient also. Is the patient coming to your clinic from far away or from the nearby? If it is a locality, you can give a near checkup date, but look at her social aspects also. Is she able to come for frequent checkup? Does she have money for the transport? Please let us think in the palliative care way. Okay, thanks.
Yes, yes. Thank you, sir. Thank you, sir.
Any other colleague, dear colleagues, I'm inviting your discussion and valuable comments.
Any other questions on nausea, vomiting before we proceed to constipation? And I think it is important to go through the diagram that he has shown in the beginning, because in palliative care we follow mostly a mechanistic approach in management of nausea and vomiting. We will be prescribing antiemetics according to the mechanism. So the diagram which was shown in the beginning, like 5 centers, and if it is anticipatory nausea and vomiting, which center is involved. So accordingly, we can prescribe antiemetics. Same way as you asked, Dr. Vandana, what happens when opioid-induced vomiting? So we have to think why morphine causes vomiting. Where it is relying, whether it is D2 receptor or it's serotonin receptor. Accordingly, we have to choose the antiemetics. The diagram gives, I think, a little bit an idea about the mechanistic approach. Along with the step ladder, we have to keep that in mind. We have to understand the mechanism, understand the center involved, understand the receptors involved, and then choose the drug according to the receptor involved.
Yeah.
So always we have to ask whether it is if it is a chemotherapy, why do we give ondansetron? What is causing that vomiting? Which center is involved? CT is it? Which receptor is involved? 5-HT3. So why should we give ondansetron? Because that is a 5-HT3 receptor blocker. So that way, if we think we can effectively manage nausea and vomiting.
That's a good input from Dr. Sridevi. Thank you very much for the addition, ma'am. Yeah. So the cause of the vomiting nausea is clinician to identify and then and approach in both pharmacological and non-pharmacological. The drugs and the discussion with the patient. 2 Ds: drugs and discussion with the patient and the family. And that's what. Exactly. Okay. Any other question or comment? If not, we'll go to the next topic. May we shift to the next topic, constipation?
Yes, I think there are no more questions in the chat, but meanwhile, we can take in the end if there are any questions.
Okay, thank you very much. Okay, so constipation definition was the passage of small and hard feces infrequently and with difficulty. It is third most common symptom after pain and anorexia. So the range of is 32 to 87% of cancer patients complain of constipation. Actually, they don't complain. They have this symptom, but they don't utter it by themselves. They are very much shy of discussion on this issue. So it's the clinician who is to dig it out at the consultation. So the constipation can cause pain and suffering and loss of dignity. Healthcare providers mostly see constipation. Okay, I can see one thing from Dr. Rivetti. We will go to the chat after the presentation, please. Let us go through the slides, run through the slides, and then we'll discuss the question. Please wait, bear with me. So the range we have mentioned, constipation can cause pain and suffering and loss of dignity. Healthcare providers mostly see constipation as a low priority. Yeah, like it's not a to undermine anybody, but us. We have to be more careful of asking in the history taking part that for question we ask when the cancer patients comes in the consultation: do you have pain? Right? Do you have? Are you eating well or not? Do you pass toilet? Are you passing urine and stool well? Or are you sleeping well or not? So on that part of, if we don't ask the patient that are you passing toilet well or not, are you pooping well or not, the patient usually don't speak about it. A very less few amount. Like I can say in my practice in Lesotho Oncology Clinic, I have seen maybe 1 to 2% patient and relative, they talk about by themselves about the constipation, but 98% patients, they just want to skip that part. So until I ask the patient about the bowel habit and passing toilet. So anyway, so most of the patients had the problem of constipation due to embarrassment of talking about constipation. And bloating is a sensation of constipation. Some patients can say that, okay, doctor, I have a bloating sensation in my stomach. Next slide, please. Okay, how to assess the constipation? Usually when the patient talks about, like we talk about the bowel habit, we ask the quantity and quality of stool and length and time taken to defecate. Is it a prolonged time taken before passing the toilet, or like too much the maneuver to pressure? If diarrhea or overflow, or the patient is like experiencing continence or incontinence, is that diarrhea? How is the diarrhea? Is there any, like we have to assess putting in our mind, is there any tumor in the large gut? So the patient can have diarrhea that is not usually usual diarrhea. It is due to the tumor inside the large gut. So is there any continence or incontinence? Effectiveness of laxative, is the laxative working on the patient? Is it previously prescribed or not? Use of complementary therapy is needed. Diet and fluid intake, how is it? And satisfaction of environmental factors like comfort and privacy for the patient is there or not. The environment the patient is staying, we have to ask about it. Does he use a common toilet, or like is there any privacy when he or she is going to the toilet, or the person staying near to him, the caregiver? Does the caregiver has good relation with the patient? Then the patient can be open up. Okay, now I want to go to the toilet, because for low ECG, like if it is ECG 0 or ECG 1, they can go by themselves to the toilet. But 2, 3, 4, when the ECG goes down, the performance status goes down, and the patient needs somebody to take him to the toilet. So these are the things in palliative care to be looking in very carefully as a palliative care practitioner. So does the patient need also abdominal massage before the toilet, going to the toilet? Okay, next slide, please. There is something called, it's in the internet also, the Bristol stool chart. The type of the stool, if it is a separate large hard lumps, it is severe constipation. The type of the stool is dark brown color. And if it is lumpy and sausage-like, is type 2, which shows mild constipation. And a sausage type with the cracks on the surface is normal stool. There are so many, like a smooth, soft sausage or a snake is normal, and the soft with the cut edges is leaking fiber, and mushy consistency with ragged edges or mild diarrhea, and liquid consistency is severe diarrhea. Next slide, please. Okay. How to assess the diagnosis? If there is fecal impaction or presenting as a diarrhea, intestinal obstruction by tumor adhesion, nausea, abdominal pain, urinary urinary incontinence, which will need abdominal examination, and constipation more than 3 days, obviously we will need to do the parectal examination to exclude the fecal impaction. Next slide, please. Now, what are the implications of constipation? If the patient is anxiety, experiencing distress, which causing hot feces, abdominal or rectal pain the patient is experiencing, does the patient has urinary retention, intestinal perforation, mental confusion, inadequate absorption of drugs, rectal tears, anal fissures, or hemorrhoids? Is there any bowel obstruction, fecal impaction, nausea and vomit, and abdominal distension? Next slide, please. Other contributing factors to constipation, like malignancy, pharmacological factors like opiate, as Dr. Vandana was asking, the opiates can cause constipation. Yes, very commonly. Iron supplements also, antacid preparations, diuretics, anticholinergics, and antiepileptics can cause the constipation. Metabolic disorders like dehydration, hypercalcemia, diabetes mellitus, uremia, and hypothyroidism can cause constipation. Neurological disorder like spinal cord compression is very important. We have to look for it. Structural abnormalities like pelvic tumor mass, radiation fibrosis in cervical cancer, anal fissure, and the dietary factors, mobility, environmental factors, lack of privacy, and old age. Those are the factors for constipation. Next slide, please. Bowel habit to be compared when a patient comes in the consultation. Compare the time of like before getting sick and after getting sick. Is there any change in the bowel habit, which gives us a lot of cue for diagnosis? Abdominal examination to be performed properly, parectal examination to be performed, leakage of fluid, feces, pus as an impacted mass can mimic diarrhea, unexpected nausea and vomit should be examined for constipation, and abdominal pain, the effort of colonic muscle to propel hot feces can cause abdominal pain, which is colic in nature. Next slide, please. What are the investigation? Actually, in palliative care, we do prefer minimum investigation, and which is mostly necessary abdominal X-ray to differentiate between constipation and obstruction. Obviously, there will be those air fluid levels in the obstruction. Blood sample investigations like thyroid, T3, T4, TSH to be done in constipation. History and clinical examination are the main guide to detect constipation. Next slide, please. Okay, let us have a look at the stool softeners and stool propulsive the drugs. So softeners are those drugs like commonly used, as we all know that lactulose in all over the world, and sorbitol, macrogols, and suppositories, glycerin, bisacodile suppositories. Next slide, please. The stimulants like Senacot and bisacodiles, what do you call it? In different part of the world, they have different names, but preparation is the same, Senacot and bisacodile. Next slide, please. There are enemas like saline retention, 5 to 15 minutes, useful in impaction. Sodium phosphate retention and oil retention also can be used as enemas. Next slide, please. So there are some treatment for constipation we all follow. First line laxatives can be combination of a softener like lactulose and stimulant like Senacot. And if no improvement with first line, then we switch to the second line laxatives like rectal suppository and enema. And clinicians may also consider methyl naltrexone, especially in opiate taking patients, like those patients who are on morphine or tramadol or methadone. Like if the patient is on opioid analgesics, if no improvement with the second line, then switch to the third line laxatives like methyl naltrexone plus manual evacuation, rectal clearance under sedation. But the best laxative is mobility of the person. If the person is good ECOG 0, 1 or a low ECOG like performance status 2, 3, 4, even on the bed, it is possible to give a little bit mobility to the person having constipation, which will benefit for passing toilet. Next slide, please. So how to prevent the constipation? Always prescribing laxatives for the patients using opioids. Ensure privacy for patients while going to the toilet. Encourage fluid intake. Always assess all cancer patients' bowel habit and discuss freely with patients and their families of their concerns. Next slide, please. Thanks for listening, colleagues. Let us have your input also. I would like to invite the colleagues to put their input, comment, questions. Madam Sripa, can you please read the messages in the chat box for me?
Sure, sir. Dr. Revati's query was whether step ladder depends on basic causes, and she also asked is domperidone which does not cross BBB modes.
Is a question or comment I don't get, but I can see the domperidone is in palliative care this side and also European side. They don't suggest domperidone in nausea vomiting, but I have observed in Bangladesh on the cancer specialist, like both radiation specialist and chemotherapy specialists, they use domperidone. They used to use domperidone. But the mechanism of action of the drug wise, I think domperidone, metoclopramide is more effective than domperidone. I think so. Yeah, if you have any other ideas, dear colleagues, you can give the input now. Then I can also learn. There is no barrier for that. But metoclopramide is a drug of choice with ondansetron, yeah, or gansetron or other cetrons, yeah. Dr. Revati, is your discussion well answered, or I don't know, you can ask again anything else or your comment, please.
I can see another question about management of constipation in chronic constipation in spinal cord injury.
What is the question, please?
Management of chronic constipation in spinal cord injury patients.
Okay, so palliative care perspective, like spinal cord compression patients, both pharmacological and non-pharmacological. So obviously the radiation oncologist will treat the spinal cord compression if it is in the good time frame, but we'll use the laxatives like according to the step ladder and the movement of, is it possible the patient can be have minimum movement exercise every day, which will stimulate the patient to pass toilet, I think. Do you have any other idea you can add with me, please? Any colleague here?
Anyone else who deals with spinal cord injury patients and constipation, you can share your ideas. Like we have here patients with spinal cord injury, and it depends on the patient's level of injury, at what level the injury is, whether it is, I mean, depending on that, the bladder and bowel can be managed, because sometimes it will be, we may have to give round the clock laxatives, but sometimes you can manage with suppositories. Suppositories becomes easier to manage because the caregiver finds it useful. We give laxatives, they don't know. Most often the caregiver has to go for work or do some other things. So suppositories, before taking bath, they can keep the suppository and manage things in a practical way. And it also, as I said, depends on the level of injury. Also.
Thanks for the input, Dr.
Sripriya, I can't access the chat
Yes,
somehow.
ma'am. Yes, like I am getting a little confused because okay. Now you have been renamed. I am forwarding the previous questions to your private chat
Okay.
so
Okay.
that
Still,
I
I'm
can.
unable to open the chat.
Sorry, Madam Sipia and Dr. Sridhar, I can see one question here. Dr. Vandana Kulkarni, again to everyone. When we start antiemetics with opioids, how many days should we ask the to take them? Rather, after how days should they stop? Okay. Uh, uh, Dr. Vandana, yes, a very good question. Like when you start antiemetics with opioids, how many days we should ask, and when to stop them. Actually, all opioid medications, when we prescribe the antiemetics and the laxatives should be prescribed along with. We don't stop them. That is the ideal regime for the prescription of opioids. Thanks. Yes, Dr. Vandana, any comment on that?
Thank you, sir. Sir, actually, for laxatives, it stands like we continue it whenever we prescribe opioids. Does it stand for antiemetics also? Because my concept was that when we start the treatment, till the patient gets used to the opioids, they have nausea and vomiting, and then over a period of time, the intensity of nausea and vomiting decreases. So that's the reason I wanted some clarification that
Yeah.
do we ask them, or is it like a concept that the metoclopramide and the laxative have to be continued till they take opioids? I just wanted a
Okay, good
clarification
question.
regarding
Okay, good question. So when we prescribe in palliative care, when we prescribe the opiate analgesics, uh, along with it, we prescribe the antiemetic and
laxative.
prevention of laxative together for
Yeah.
the same time of
Yes.
the opiate prescription from the
Yes,
same
sir.
direction until you withdraw it. Yeah. And until you get the adverse effect like severe diarrhea, then you stop the laxative. Okay,
Okay, sir.
thank you very much.
Okay. Thank you, sir.
Yes, Dr. Sharon, the hand is up. Madam Supriya, please. Okay,
Yes,
yeah.
actually, in response to Dr. Vandana's question, actually, I think I've read in some palliative care books also that nausea and vomiting, which is opioid induced, actually the patients usually will develop tolerance to that fairly quickly. It's not like constipation, which is an ongoing side effect. So if I'm not mistaken, I think 48 to 72 hours, usually the patient develops a tolerance to nausea and vomiting, and most of them will not require beyond that. It's just PRN after that. I mean, I myself actually have not come across any patients with long-term nausea, vomiting, even when they are on opioids. So that's just my take on that.
Thank you very much, Dr. Sharon, for your input. It's very important. But in prescription of opioid and for long duration also, it is advised why it is advised to use opiate plus the antiemetic and the laxative. The reason is that opiate has different adverse effect like emesis, constipation, and also central CNS effect, right? Central nervous system effect, for the CNS effect, the opiate tolerance within 5 to 7 days. But for constipation and for vomiting or nausea, it can go for prolonged period also. So what we practice in palliative care, ideally to prescribe for any duration of opioids plus the antiemetic and the constipation until the patient has severe diarrhea or any other adverse effect for that drug. Thank you.
Thank you so much. There is another question about when to give enema. Do you prefer enema for constipation or laxatives?
Okay. The first line, second line, and third line we have seen in the slide. So enema is not the first approach. We try we prescribe that for constipation, the laxatives and stool softener and the propulsive drugs, like lactulose, the osmotic drugs, and the other drug like the bisacodyl or the Senacot. And then when it does not, after the following checkup, when the patient comes to the consultation, it is not working, then we switch over to enema. But before enema, we need to make sure that is there any impaction of fecal matter is or not by doing the parectal examination, and then we switch over to that lineup of treatment. Thank you.
So just to share our experience in Pallium India, we have a very strict bowel protocol. We make sure that the patient has proper bowel movement every third day. So as Dr. Hassan was mentioning about when you ask about pain and other symptoms every day during the rounds or over the phone call or whether it is an OP visit, we make sure that we ask about the bowel habits, and it is a very commonly shared concern that the patient is not eating anything for quite a long time, so they don't expect a bowel movement. It is our duty to tell them that it is not directly to the quantity of food that they eat. You can actually, I used to tell them that it is not just the food that comes out in the fecal matter. There are so many other things, including water. And even if the patient is dying and not on any hydration also, still they have to have proper bowel movement. Otherwise, it will cause a lot of distress. So the moment you ask about the bowel habits, they'll tell you he's not eating. He has not eaten rice for a week. So it is okay. So we have to make sure that and tell them that it is not okay. We expect a proper bowel opening even if they are not eating or drinking. And as Dr. Hassan mentioned, we use laxatives, especially for opioid-induced opioid patients, definitely for lifetime probably. And we make sure that third day still they don't have bowel movements for 2 days. Then the third day we do a rectal examination, and depending on your examination, you can give suppositories or enema. And when there is a high up impaction, we do a high up enema in our setting. We attach a suction catheter or a NELCAT to the enema sachet and go as much as possible, so you bypass the fecal matter up which is impacted higher. So that's how we follow here. I thought I'll just share the experience here.
Thank you very much, Dr. Sridevi, for sharing this idea. Actually, we all share, then we come to a like common idea which you can practice all over the world. May I please ask, I can see Dr. Ian Ferrer, can you please unmute yourself? Can we know your input also from, I don't know which part of the world you have joined the forum today, and your idea of constipation, what Dr. Sridevi just placed on the table. Hi, Dr. Ian.
Greetings from the United Kingdom, where it is warm, about 26. Broadly speaking, it is very, very similar, although we work in a general practice setting in the community. So we use less antiemetics because we often find we can introduce opiates without problems at low doses. Although whenever I write a prescription for an opiate, I would always write a prescription for a laxative on the same prescription. The two things are linked in my mind and always come together. And I would echo what you've already said about checking regular bowel action and attention to all of the other things around that diet, and particularly fluid intake is something that I find is the biggest problem. People don't drink enough. Sometimes when you explain the mode of action of the laxatives, particularly the bulking laxatives and the lactulose, so I write on the prescription for lactulose to consume 2 to 3 liters of fluids daily. And then I say that's in addition to any tea and coffee. So that's what I would say. There's nothing much more to add from a UK perspective.
Thank you very much. Dr.
Yeah,
Yan, thanks a
that's
lot
helpful.
for your input. Yeah. So now, Madam Sripriya and Dr. Sridevi, I've been given 60 minutes of presentation. I can see on my table clock that is only 50 minutes discussion and presentation. I would love to hear from my colleagues in India and Myanmar. Also, if I may be allowed to ask other colleagues, like I don't know whether I should name the doctors whom should I like? Dr. Rishikesh. Hi, how are you? Dr. Rishikesh, which part of India are you joining from?
Hi, I live in Nashik, Maharashtra. I'm a graduate and I will pursue, I'll study further in surgery, and my interests are community health, rural health, and palliative care.
Great.
So I'm currently not practicing.
Okay, are you enjoying this? There's a discussion today.
Yeah,
In
definitely.
palliative care. Okay, well, hopefully we will get a new generation palliative practitioner in future. Okay, any other colleague from today's session wants to discuss or give any information on nausea, vomiting, and constipation? Please raise your hand and put it on the table. Dr. Manoj Patruni. Hi, sir.
Hi, sir. Good afternoon. I'm a community physician. I did my MD community medicine and I'm interested in palliative care. Even though I'm actually a state consultant for non-communicable diseases from World Health Organization India. So my future thought is about to start up a clinic and so even practice in some corporate hospital. So I just wanted to learn and gain some knowledge on this.
That's great intention. So be with us. Okay. So you have mentioned about the palliative care practice for future. Actually, when the patient, if a person has like those symptoms of having cancer treatment, a burden, and then with nausea, vomiting, or constipation, it huge deterioration of quality of life. That's why this discussion is very important, and let us practice it in everyday clinical environment.
Yes.
Thank you for being with me, all colleagues. I will hand over to Madam Sripriya and Dr. Sridevi for the follow-up continuation of today's session.
Thank you. There are two more questions. One is about the side effect of long-term use of laxatives. Would you like to comment on that?
Actually, I'm not so much pharmacology know-how, but as regular practice in palliative care in the oncology clinic, like I have not yet observed any adverse effect of long-time use of any laxative, but there might be like depending on the individual, like diarrhea will be the most common side effect expected if for long time use of laxative, but it is not observed in my practice. Thanks.
And about any specific diet and non-pharmacological techniques in managing constipation.
Yeah, obviously it will also depend on the individual, like somebody like as the lactose intolerance, some person can have problems with a specific diet, the other will not. So it is not easy to categorize that which food is good for, because for everybody. Like it will depend on person to person's bowel, really. Yeah.
Yeah, just to add on to that, Dr. Jaya, I think when we advise diet and other techniques, it's important to understand whether the patient is able to follow that diet, because many a times we say next comment is on high fiber diet. May not be possible in many patients. And when you are giving opioids, the high fiber diet is something which can actually aggravate the constipation. It increases the mass, it increases the content, the bulk. And many a times patients may not be able to eat what we advise, right? They might be taking a few sips of soups or juice. So we have to be a little careful when, at least in our practice, that's what we see. A little careful when we advise diet, because then they feel little guilty about for not having been able to do the diet properly. So that's all I wanted to add on to that. Non-pharmacological techniques, yes, like sometimes we tell them to have hot water and try to go to the loo in a particular time, maybe after a few, especially for spinal cord injuries, we tell them, even if there is no bowel opening, we make them sit in a commode chair so that after a few weeks, they get used to that routine very commonly. So bowel training is important. As a non-pharmacological technique. We always encourage them to eat fruits in our culture, right? We tell them to eat bananas and papayas and things
Very
if
true.
they are able
Yeah.
to. Yeah, that all we can do. But just to be careful about whether they can eat it or not, what they can eat, and accordingly we can. Sometimes we say drink a lot of water. Probably patients may not be able to drink that much water. So
True then. Yeah.
that's
Thanks
all.
for the
That's all
Dr.
from my side.
Yeah.
One more question from Dr. Vandana. Can we advise stimulants and softeners at the same time? Or we add on after starting with the softener? Dr. Vandana, I assume that this might be for the opioid-induced constipation that you are asking, or?
Yes, ma'am.
I'll just share the practice here. We start with the stimulant. Never start with the softener alone. Because why opioid is causing constipation? Because of the motility, right? It inhibits the motility action in the gut. So you definitely need a stimulant to start with. If you want to start with one, it is definitely the stimulant. Then I prefer to add the softener after 3 days. Anyway, we'll do a phone call review after 3 days, how their pain is and everything. And then we ask for the bowel movements. And if still constipated, we add on a softener on the 3rd day onwards. Because suppose if we give, there is no harm in giving together. There are centers where they give stimulant and softener together. And that is what is recommended. But suppose if they end up in having loose stools, then they'll be very scared to take the stimulant also. So in the beginning, we don't want any glitch when they start on morphine. So here we start with the stimulant, follow up after 3 days. And if they say it is still difficult to pass the stools, then we add a softener. But it can be given together also. There is another question, some concerns about chronic use of stimulants such as bisacodyl in literature. Any such observation in clinical practice? I think that's what Dr. Hassan was telling. In his clinical practice, he has not seen any problems with. In my practice, also in last 10 odd years, we have not seen any problem in chronic use of stimulants because most of the patients on stimulants are on opioids. Majority, very less we have patients who are on stimulant laxatives without opioids. Maybe elderly patients. But I personally have not seen that in clinical practice. Yes, Dr. Sharon.
Yeah, I just wanted to raise another question. In patients, with pelvic tumors or rectal tumors or cervical malignancies which cause a rectal lumen narrowing, in such patients, what would the ideal or what would be the preferred laxatives to be advised if they are on chronic opioid use?
Okay. Thanks for the question, Dr. Sharon.
Narrowed like lumen. Yeah.
Yeah. Yeah. Because it's a mechanical obstruction in the lumen because of the tumor, as you are mentioning. So obviously, there is if you like, yeah, we have to be careful a little bit using the. So in that case, let us start with I think ideally it will be softener. Stool softener will work much because propulsive will not work on it because of the mechanical obstruction. Thanks.
Thank you. Thank you, everyone. I think we'll take up the case presentation right now and we'll have further discussion after the case presentation.
Good evening, Rolando. Am I audible?
Yes, yes, please go ahead.
Yeah. I'm Dr. Jaya. I'm working as assistant professor in the Department of Anesthesiology, JIPMET Karaikal. Today, I'm going to present a case with the GI symptoms. It is a 52-year-old female who is diagnosed to have chronic radiation enteritis, who is a case of CA endometrium post-hysterectomy with EBRT and brachytherapy. Next slide, please. Yeah. She presented with diarrhea with 6 to 8 times per day, and that was presented for 2 to 3 days per week. It is mostly in water in nature, and sometimes it is only the blood is coming out with clots, blood clots, and it is associated with abdominal pain, severe abdominal pain, colicky type of pain. Next slide, please. She is diagnosed with CA endometrium and diabetes 3 years before. She underwent TAH, and after 6 weeks after surgery, she undergone radiation with EBRT and brachytherapy. During radiation, she didn't have much symptoms. Only in the later part of the EBRT, she had mild nausea and vomiting. No bowel symptoms were there. Then she was fine. Now she came with the complaints of diarrhea and hematochezia, causing the blood stools for the past 5 days. That was continuous. Previously, she was having loose stools initially for the last 2 months, then now presented with hematochezia continuously for the 5 days. She also complains of fatigability, and she is feeling dyspnea on exertion, and she feels dehydrated also. And past history, she is a known case of hypothyroidism for the past 20 years. She has undergone subtotal thyroidectomy 10 years. From then, she is on supplements for thyroid, and she also have history of 2 previous LSCS, which are complicated with wound infection, and also she had history of septic arthritis in the right leg, which is not having any effect at present. Next slide, please. On examination, she is obese, 70 kg with a height of 145 centimeters. She looks pale, and there is mild dehydration, and the heart rate is 100 per minute, and the BP is 170. And CVS no signs are there. And RS, there is respiratory rate is 25 per minute at rest, and there is no added sounds are there. And abdominal examination, the abdomen is soft, there is no, but increased bowel sounds are there, and no distension or ascites are there. Next slide. On investigation, she has shown basic investigation showed HP of 7, so she was transfused 2 units of blood, and endoscopy showed multiple bleeding spots up to 30 cm proximal to the cecum. So she was initially treated with to stop diarrhea with loperamide, and to prevent bleeding, and she was advised with liquid paraffin 30 ml HS, and also to improve the probiotic. She was advised Yakult, that is a probiotic syrup, TDS. And whenever she, as because she is able to take, she is not complaint of vomiting, she was advised to have oral rehydration salts. Whenever she feels, whenever she have diarrhea more, and if she advised, as it was, she was tolerating orals, it was managed with only fluids. And even after 2 months of conservative treatment, the patient continuously having the hematochezia, so she was advised to have organ plasma coagulation each setting every 2 weeks for 10 setting. With that, the frequency has decreased, but still the patient was having the mild hematochezia, that is once in 3 weeks or once in a month she was having the hematochezia, but it was improved overall. Next slide. Psychosocial aspects, as because she is known case of CA endometrium, she first diagnosed with bleeding, postmenopausal bleeding. So when she found the bleeding from her stool, she thought that it may be a recurrence, and she feared of death. And now, as because she is having continuous stool, and even she is not able to control the stools, she was having social stigma, and she could not stop, not able to go to any relative's house or anything. So she was feeling very depressed because she's not able to socialize as she used to do before. Especially because she used to go to the churches regularly every once in 2 days. Now she could not able to go to the churches or any gathering meetings. So she was feeling very depressed. Next slide. The medication she is on, she was diabetic and she had some dyspnea on exertion showed the RV dilatation, so diastolic dysfunction. So she started on diet or OD, and other supplementary drugs were given with liquid paraffin also. So next slide now. The main concern is the frequent diarrhea with blood. The blood part is being controlled with organ plasma coagulation, but still she is having the diarrhea. So she is not able to make the socialization is the main concern for her. With whenever she has the diarrhea, she was having abdominal pain also. That also another concern. And because she developed anemia and not able to take the nutrition properly, she was having frequent muscle spasm. That is the main concern for her at present. Summary: 52 years old female, known diabetic and hyperthyroidism, post TAH with radiation for CA endometrium, now present with after 3 years chronic radiation enteritis. Still, she is having the frequency of, or even after the treatment with APC, organ plasma coagulation, still see complaints of hematopoiesia once in 6 months and frequency in diarrhea once in a week. Okay. Next slide. The discussion points, the treatment options for hematopoiesia, I want to know, and dietary advice for this patient, and any options whenever she has stools, any other options are there for her to socialize in this situation. Thank you.
Thank you, Dr. Jaya, and thank you specifically because she came up with this presentation yesterday evening. We contacted her and she volunteered for bringing up this case presentation because Dr. Samiran could not do this because of some family emergency. So thank you so much for volunteering, and this is exactly what we look for from you all. Thank you so much. Special thanks for that.
Actually,
yeah.
she is.
Yes.
It's a case I got some 5 years before. I could able to remember only this much. Sorry, I could not get the proper.
No problem. No
history.
problem. No problem.
Yeah.
Thank you so much. And this is slightly different. We have covered nausea, vomiting. Now we are covering another aspect of GI symptoms, which many of you may come across very often. So over to the participants, and before asking Dr. Hassan, over to the participants, what do you think? And we would like to hear from you. How do you manage? I understand there are a few oncologists in this group. So probably we would like to hear from you how you manage this kind of situations. Very important question, Dr. And many a times when we see a symptom, we relate that directly to the cancer, probably. So there is a question: has metformin been considered as a reason for a loose stool? I think, yeah, that's a very, very important thing. When we think about correcting the correctable, we sometimes jump directly to the cancer. How, Dr. Ian, would you like to share how prevalent it is, how strong the association between metformin and the loose stool in your practice?
In the community with patients, it's surprisingly common. It's interesting, it comes when you ask them the question, do you get any loose stools with the metformin? And the other surprising factor is that they can develop it even after they've been on metformin for several years of successful treatment. Sometimes the slow release preparations help reduce it. And sometimes you have to reduce the dose back down. So it's much more common than you think. A bit like constipation. It's only when you ask, you find out how frequently it causes trouble.
Thank you, Ian, for that wonderful point. Even I need to keep that in mind. We don't generally ask about it when we prescribe. Most of our patients in the community are on metformin. But yeah, thank you so much for that. I guess other participants also got an insight about it. Any other comments? I mean, how to manage this particular situation? I wish some oncologists come up with some solutions. I'm waiting for the chat. That's why it's silence. I think there are no comments in the chat. Local steroid enema. Yes, Dr. Mohammed Sajid. Doctor, would you like to explain how you give that steroid enema? Like it's found to be very useful in controlling the loose stools, especially uh, just for the sake of learning. Would you like to? I personally have learned the theory, but I've not used the steroid enema. But there are many centers where they practice steroid enemas for controlling loose stools. So it will be good if we can share how do you use it. Either you can type or you can unmute and speak if it's possible. So Dr. Rishikesh is asking about adult diapers culturally acceptable. What do you think, others? I can think of. Yes, Dr. Mohammed.
Yes, yeah. See, we are aware of the anti-inflammatory effect of steroids. We are also aware of our experiences with dealing with ulcerative colitis patients, especially when they have proctitis, as well as rectal involvement. So one of the treatment planning in these cases are usage of steroid enemas. So that it's just the same application that we use when we have inflammatory process going on in the rectum, and that actually is the only principle that is needed. So usually given as BD dose, advantage of that it is not having any systemic effect. So that way it is very useful in these kind of scenarios. That is the basic principle of using steroid enemas.
Thank you, Dr. Mohammed. And how far do you repeat it? Like, what will be the frequency? Is till the symptom subsides, or?
Exactly, yeah, till the symptoms subside. And one of the advantages, since it's a locally acting, we can use these kind of enemas, not to worry about the absorption part of it. Mesacol enemas are also being used because they are also being used in the local effect to cause the local effect in ulcerative colitis patients. So you can very well use this same principle.
Thank you, Dr. Mohammed. So Rishikesh is asking about the cultural acceptability of adult diapers, and Dr. Jay is telling that this patient is not accepting. And what are the others think about adult diapers? I think from my practice personally, it's about the cost is usually the concern. Cost and managing the waste. That are the two concerns I personally have seen. People cannot afford to buy diapers, especially if they have frequent bowel opening, then they may have to change it regularly, or else it will lead to bed sores. And I mean, disposing the diapers, managing the waste when they are at home is another concern that I have personally seen. I don't know about the others in this group. Maybe we can see what is coming up in the chat. And Dr. Revati is asking, can Musica-Dotril can be of any help? I do not have any experience in that particular drug. Has anyone used octreotide in such cases? any experience in, oh, okay. So I just got Dr. Shun asking the same about octreotide. Any comments on octreotide?
This I've been out of practice with radiation oncology for a long time, but yeah, but you know, I mean, as a PG and as you know, as a resident, we used to have quite a bit of patients coming with radiation proctitis. Now, this being like the cause is due to the radiation induced changes in the rectum. Now, radiation proctitis, I don't know if anti-secretory or those drugs like octreotide will help much, because it's not the diarrhea that's coming from the small bowel and all. It's mainly in the rectum. So I don't know. It's used, the treatment for this is usually like rectal sucralfate enema or steroid enemas, or I suppose symptomatic management. But I don't know if the anti-secretory agents will help much, since the pathology is much lower down here in the rectum. So generally, this, if they have bleeding with it, then they have to go for laser therapy, or sometimes if it's so severe, they have to intervene surgically and do some resection or colostomy or something. But anti-secretory agents, I'm not very sure. I have to read up.
I have used one time I have used octreotide for as an anti-secretory for diarrhea. We had to go up to higher doses as continuous infusion. It worked really well actually, but that's just one experience. Yes, it is expensive, and divided doses did not work. So we had to give infusions, and we had to, although they say 800 microgram, we went up to 1200 microgram per day infusion. But that when the patient was in severe distress, it's like watery stools all the time, and he had a colostomy. And it was like every minute the colostomy bag was full with watery secretions, and he was awaiting surgery in the coming days. So this only thing which helped was octreotide infusion. That's but just one patient experience. Yes, Dr. Hassan, you.
That is for how many days? No?
So we did it for 3 days because he was awaiting surgery in the coming, 3 or 4 days. So 3 days we did it, and it had a significant reduction in the amount of secretion, and the patient could actually got good symptom relief. Dr. Hassan, sorry, I didn't ask you because in the end it was coming to you to conclude. That's why I did not. So sorry. Okay. Please go ahead.
No, he's okay. He's okay. Thank you very much. I was listening keen to the all opinions or coming in. So this is not an easy situation for the clinician to handle with. So actually, this case needs a team approach. The team, interdisciplinary team and multidisciplinary team of palliative care. And the team should consist of obviously palliative care physician with the oncologist and nurses and psychologists and social welfare officers, and also nutritionists as a multidisciplinary approach. So as you have mentioned, all the specific approaches already, dear colleagues, like radiation and the argon plasma is done, is undergoing, and also the surgical consultation, the colonoscope and steroid enema is okay. But let us also have a look at the psychosocial aspect, as Dr. Joya has mentioned. Like she has a fear of recurrence and death, and she has 2 unmarried daughters, and business as lost. So there are 2, the person most possibly having a psychological challenge of like anticipatory death, fear of death for herself. So she might be thinking that what will happen after her death to her daughters who are not married in the Indian culture. It is very important to before like the death. We expect our daughters get married or in a good family like this. So this is a challenge needs to be discussed with the patient and the family in a family consultation in a palliative care environment. And how are the finances, like the family is being managed for buying food, clothes, and other things, because the business has been lost. So these two things, like psychological and social aspects, are giving heavy impact on that patient. And then the spiritual aspect also. So later, so for this patient, a care plan should be made on the physical challenges, psychological challenges, social and spiritual, like all four domains of palliative care needs to be addressed. Thank you.
Thank you, Dr. Hassan. Thank you. I think someone else also wanted to speak. I think I interrupted in between some time back. I don't know who that was. Just taking from where Dr. Hassan stopped. So we were talking about medications, but it's very important to look at the psychosocial part. We can see we get loose tools for 1 or 2 days. How embarrassing and how difficult it is for us, right? Going to work, depending on someone to go to the toilet, and and this is a patient with malignancy and a young patient with a lot of other family issues. So we can understand how difficult it is for her to go through it. So it's very important to have the multidisciplinary team in place and talk to her while we are figuring out which medication will work. It's important to explore the concerns and how we can reduce. We may not be able to completely solve all the problems possibly, because what she's going through is a very, very difficult situation. But it is important to let her talk about it and see what can be done from our side. Maybe she just wants to talk about her these things, which she may not be able to talk to her children, or don't want to talk to the particular doctor probably. So it's very important to have a platform or a space where she can talk about all these issues. Meanwhile, we are figuring out how to deal with the medications for her. That's just, I just wanted to echo what Dr. Hassan was telling. Any other comments from the participants? Just to remind you, it's very important symptom that we are discussing today. We see it's very, very commonly nausea, vomiting, and constipation, and very distressing also, especially in advanced stages where they are already cachexic and fatigued, and then they have nausea and vomiting. And he mentioned about the fecal matter vomiting. It is not that uncommon, and it is the most distressing symptom I have ever seen. People start vomiting their own fecal matter is something which they don't want in their life. So it's very important to focus or read a little bit upon these symptoms. You have to understand the mechanism for sure. It is not just about empirical approach in palliative care. It's all about understanding the pathways, understanding the mechanisms and the receptors and the corresponding blockers. So you'll get an idea why you are using this particular medication. And that's very explicitly asked in all the assignments related to the symptoms. So please read all the centers and the receptors and the blockers thoroughly before you attempt the assignment. And again, constipation is also the most common symptom after pain. Everyone will be invariably having issues with the bowel. So make it a practice to ask about the bowel opening every single time you see the patient, every single phone call follow-up, ask about the bowel opening, irrespective of whether they are on opioids or not. And you'll be surprised to see the response. And the most common answer you will get is the one which I told, he's not eating for a week. So that's your nurse will tell you that is okay, doctor, because she's anyway not eating. So you have to tell them that it is not directly related to the quantity or proportion of what they were eating. And it is important to ask. The Bristol stool chart that he mentioned is very useful. If they cannot express or we don't understand whether they are telling constipation, just show them and tell them to show you like what kind of fecal matter they pass. It's very easy because the picture is very easy for them to relate. So that's, and we might have heard about pain, to believe the patient, to say, patient says when they say it hurts. And I think constipation is one symptom where I don't trust the patient when they say that they have proper bowel opening. Just don't trust, because it's very common and it is very distressing. And it might be the reason for the urinary retention and the delirium, confusion, the nausea, vomiting. So the commonly used question in our setting is, have you had proper bowel opening? When was your last bowel opening? Whatever symptoms they come up with, somewhere or the other, it will be related to the constipation. So it's very important to ask and explore about the constipation. Any other closing remarks, Dr. Hassan, before we wind up today's session?
Thank you, Dr. Sridevi. And dear colleagues, it was really exciting on my part to join with this beautiful team of doctors who are interested in palliative care. Obviously, Trivandrum Palliative Care Institute is a good initiative to integrate palliative care in different settings, like surgical modality, medical facility, even the other, like gynecological aspects. So I would like to congratulate the team who is working in Trivandrum, and also the doctors who have joined today from their very valuable time of practice to share ideas of palliative care.